What were we talking about?
Chemistry.
Entropy.
We covered tires,
Inevitable.
we covered tires, chemistry.
Okay, so we're back live
Horses.
from our technical difficulties. Nolan, take it away.
All right, apologies for that. Let me make sure that I'm all muted out. All right, let me reopen. Oh, I need to be able to share. All right. All right, so we're back. So we ended with the punchline. Well, if you've seen one Medicaid program, then you've seen one Medicaid program, in which case everybody laughed really loud, but that wasn't caught online. So we're still in the context of Medicaid. So nationwide, there's approximately 80 million people have Medicaid or CHIP. CHIP is the Children's Health Insurance Program. At the national level, CHIP is actually not part of Medicaid, but in Vermont, we administer it as part of our Medicaid program. And as an aside, in Medicaid, any of our children in Medicaid, which are children 18 or under, are under what we call Dr. Dinosaur, and sort of the umbrella name. So when you hear Dr. Dinosaur, we're talking about kids who are on Medicaid, but that's just like the umbrella name. So in Vermont, we have 197,000 folks who are receive some form of assistance through Medicaid or CHIP, and that is as a primary or as a secondary. So 150,000 Vermonters have it as their primary. That's about a quarter of Vermonters. Now I say this because there are times when you'll hear people in the media say a third of Vermonters are on Medicaid. It's actually not factually true. A quarter of Vermonters are on Medicaid in terms of having it as a primary. Another 46,000 of Vermonters have a relationship or whatever you want to call it with Medicaid, in that they might have some form of supplement. For instance, on the exchange, it's a private, you buy your insurance through the exchange, it's a private insurance plan. So it counts as part of that commercial bucket, but they're receiving subsidies through the state. So the state is not their primary, but they're receiving something from the state. Another example would be VFARM, right? So our Medicare beneficiaries, their Medicare is their primary, but they're getting prescription drug assistance through the VFARM program to help them pay for their drugs.
So what category would dual enrollment be?
Medicare. Folks on the bucket.
So you're on Medicare, but you get your supplemental from Medicaid?
No, well, dual eligibles is a whole other thing. I believe we get into that at some point, but dual eligibles are folks that are Medicare and Medicaid eligible. They're low income folks.
Yeah.
And so Medicaid sort of is the second. Medicare is the primary provider, and then Medicaid picks up the gap. So if someone's in the hospital and their Medicare runs out, Medicaid kicks in.
But in those numbers, where would they end up?
They would not be in there at all.
Because a lot of people that are in nursing homes end up.
Yeah, no, that's a good question. That's a good question. They might be under
They would be under the 46, don't you think?
They might be under the 46.
Yeah.
No, you are correct, Senator Westman, and we do cover that later on. I think I have that number somewhere else, but you're correct. They would be under the partial. Thank you for that correction.
I just was trying to.
Yeah. No, good. Thank you for the clarification. Okay, now this is Ashley.
Thanks. So in Vermont, in order to be eligible for Medicaid, you must be a resident of the state. You must have legal status in the country. So either a US citizen or a permanent resident, or a category called non-citizen with lawful presence, which is a pretty limited group of people. And you also have to have low income. So everyone on Medicaid, regardless of their circumstance, has a low income that varies depending on the population that you fall into. We have categorical eligibility in addition to low income, which includes pregnancy, parent, blind, disabled, or aged. And under the Affordable Care Act, starting in 2014, we also added a new category coined the new adult group, which allowed for the first time individuals to be Medicaid eligible who didn't meet categorical eligibility. So you didn't have to be a parent or have a disability, you just needed low income. So that is where we are today. And covered under the Medicaid program are a list of both mandatory benefits and optional benefits that are spelled out in the Social Security Act. Next slide. I'm hearing dogs now. Was that? There was just like dog barking from someone. Okay, it's gone. It was definitely coming from your room apparently somehow through my speaker. My audio day. So this is the list of mandatory and optional services that are allowed to be covered by state Medicaid programs. Purple is mandatory. It is kind of core Medicaid, inpatient hospital, outpatient, physician, nursing home, kind of your comprehensive medical insurance. And then the blue are optional services that states have the option to cover or not cover. In Vermont, we cover all of the optional services through our Medicaid program.
So this goes to that conversation about if you've seen one Medicaid program, you've seen one Medicaid program, because a lot of states may not cover as many optional services as we do. Now we're going to get into the fun stuff, talk a little bit about Medicaid finance. So this is another number that's kind of old. In 2020, Vermonters spent about almost $6.4 billion on healthcare. That's all healthcare. That's your commercial, Medicare, Medicaid, your out-of-pocket costs, your deductibles, etc. We don't have up-to-date numbers on that. That's part of the update I want to get from the expenditure analysis. But given the trends, it's very likely in the $8 billion range. So it's probably around $8 billion, give or take, total spending for Vermonters on healthcare. Now, this number includes, there's two ways of looking at it. There is spending by Vermonter residents, wherever they are. So that would include if I'm a Vermonter and I have my insurance here through Blue Cross Blue Shield of Vermont, and I go to Colorado and I break my leg skiing in Vail, that counts towards me. The other way of looking at it is provider. And that would be include people from New York or New Hampshire that come into Vermont to seek care. These numbers are on behalf of Vermont residents. So that's the way we're thinking about it in terms of people that we cover, our insurance companies cover, etc. So that's kind of an aside. Medicaid accounted for about 27% of total Vermont health spending. That number probably hasn't changed. But this number has big state implications. So this is the budget from 2024. Total appropriation was $8.7 billion. $2.3 billion of that was for Medicaid. And this is all funds. This is the amount of money that you have appropriated, state, federal, special fund, etc.
When we talk about the cost of these programs, this is the cost that Medicaid kicked in to pay for services. So this does not include things like out-of-pocket deductibles.
This is just what Medicaid spent.
Okay.
Not what the consumer spent.
So when we talk about, that it costs maybe about $8 billion.
So there's two numbers here. The
Okay.
last number was total health spending across the whole spectrum.
Okay.
Teachers, blah, blah, blah.
Right.
Now we're narrowing down to just the state budget.
Okay.
The state budget for what we appropriate, you guys in this room appropriated, last year we appropriated $8.7 billion. $2.3 billion of that appropriation was for Medicaid.
Okay. And so is it reasonable to say that it might actually, if we were to include, say, out-of-pocket expenses, it could even be more than that? Even with that total?
No, because two different numbers.
Okay.
So the other number, the $8 billion
Everything.
is all healthcare spending.
Okay.
Right across the state, no matter who, for what, out of pocket, commercial, Medicare, it's just all spending on behalf of Vermonters. Now we're just talking, because there are close numbers,
Right.
we're just talking about the state budget. This includes K-12, commerce, right? We're not just talking healthcare.
Okay.
Right, it's more than healthcare. That's why it's weird that this number is larger. because this includes personnel costs and other
Yeah.
things that
Okay.
aren't.
Oh,
healthcare.
okay.
Administration.
Oh,
Yeah,
okay, I
administrative
see.
costs.
It actually just shows you the breadth of the
Transportation.
expense of
Yeah.
healthcare in Vermont. It's almost as big as the state budget, right?
Right.
So 2.3
Thank
billion
you.
of that, no, it's a
Yeah.
good question. So, but it gives you a sense. And what actually makes it a little more confusing is that I talked about how 27% of Vermonters are on Medicaid. Well, 27% of the state budget is spent on Medicaid. So there's another number that is similar, the same number, but we're talking about two different things.
And the K-12 number, what is that number actually?
That's just what we spend. It's probably Ed Fund.
On what, though? Like on
Now,
this isn't teachers' healthcare, right? This, because this is,
teachers' healthcare might fall in there because it's an Ed Fund expense.
okay.
Yeah, the current teacher's healthcare.
That's right.
Whereas teacher healthcare would, in the last example, the 8 billion, teacher healthcare would be in there because that's a health expense.
Right, some are in both
So-
graphs,
So,
both numbers, right?
Yeah.
so in the schools, you're talking about the Medicaid piece in the schools?
No.
Is that what?
No,
This looks
Medicaid.
like the green is not Medicaid, the green is state.
No, I understand Senator Westman's question, and the stuff that you're talking about, the sped med, that stuff,
The sped.
that would be under Medicaid because Medicaid's paying for that.
Right,
Although, actually, you're right, it does get confusing because the schools spend it and we get reimbursed for it. But that's a rabbit hole. Let's not go down there.
Yeah.
But your point is well taken. It's not clean.
no, and we get a lot of that sped med for, from school nurses.
Yeah.
There's a,
Yeah.
And property tax adjustments, why is that?
Yeah. and this is-
You know, I didn't make this chart. I would say,
yeah.
bring
I
it,
like that group.
blame it on Emily
We
Byrne.
need it.
This is, this is just the state budget, this doesn't have any, this is not a budget about healthcare.
This was just context.
This is just showing us how Medicaid gets to 27%.
This shows us what a big part of the state budget Medicaid is. That was the point of this
2.3
chart.
billion.
Yeah, that was the whole point. It wasn't intended, it was meant to be for clarity and not for confusion.
Right.
That's all it was.
So everybody could join us in health and welfare and go further, right?
Sure, we need a bigger room now.
Okay.
So, again, in the context of the state budget, 8.7 billion, the total appropriation, and I have this little illustration of the dollar, just to give you a sense of what percentage of that is Medicaid spending. And this is all funds, state and federal, and it's 27% of the state appropriation. So ironically, it's 27% of spending or coverage, and it happens to also be 27% of our state appropriation.
Well, that
Doesn't make it confusing, no?
in K through 12 education, there's
Yes.
not much left.
Well, if you look at this chart, you can see those two
Right.
take up a lot of the chart. So in talking about our federal spending, so we have $3 billion in federal funds, which is 36% of the state budget, and 40% of that 36% is Medicaid. So just to give you a sense of our federal dollars, how much of those federal dollars go towards Medicaid. So again, overall, we have $2.3 billion in Medicaid expenditures. Now, that's state and federal, and one of the terms we talk about is this thing called FMAP. You're going to hear FMAP a lot. It stands for Federal Medical Assistance Percentage, and this is the way, or this is the calculations that the federal government uses to match our state dollars. Now, most of our Medicaid is FMAP, not all of it. There's some other federal dollars in there from grants and other stuff, but most of our Medicaid program are federal dollars. And our match ranges between 50 and 90%, depending on the purpose. And I'll get into that in a moment. But I want to talk a little bit about what is FMAP, how is it calculated? And basically, it's a complicated formula, but the easiest way to describe it is it's basically a 3-year average of state per capita personal income compared to the national average. So it's this formulaic that they come up with, and you can see that states that have very high per capita income, California, Connecticut, New York, New Jersey, etc., they're hitting the cap because no state can have less than 50% or more than 83%. So those really high per capita states are hitting that sort of cap. They can't go any lower. Now, the higher the FMAP, the better it is for us. The flip side is, the higher the FMAP, the worse we are doing financially per capita income, right? So whenever we see that our FMAP has gone up, which means we get more federal dollars, we're always like, yay, but it's indicative of the fact that our personal income is actually down. Whereas when our FMAP goes down, we're like, boo, it costs us more money, but it's actually indicative of the fact that our per capita income has actually gone up. So it's this weird story. These are the FMAP rates. So we have multiple FMAP rates. Most of the Medicaid program falls under our regular FMAP, and that's the first one. So it's 58.81% federal, 41.2% state. This is on the state fiscal year. This is the majority of our expenditures. And one way to think about it is for every Medicaid dollar we spend, we're getting $1.43 in federal match for a total spend of $2.43. So in other words, for every dollar we spent, we're getting $2.43 in service. Flip side is when times are bad and we're looking to cut money and you cut money in Medicaid, for every $1 you cut, you lose $2.43 in services. So it cuts both ways, literally. We also have the Children's Health Insurance Program. This is a smaller program. It's about 4,000 kids, 4,400 kids, but we get about a 70-30 match on those kids. Then we get a 90-10 match on our expansion population. We refer to them as the childless new adults. When the Affordable Care Act passed, this was that expansion population. And the reason that the FMAP on this is so high is because a lot of states had not expanded like we did. And so by the federal government requiring states to cover more people in this expansion, they were giving states that hadn't done expansion, they were covering them 100% for a period of time. And states like us that had already sort of been covering them through other programs prior, we were getting 80-20. And then over time, over a series of years, everybody just sort of met in the middle at 90-10. And it's 90-10 in perpetuity. So until Congress makes an action or limits the Affordable Care Act or whatever, it will continue to be 90-10 for that group. The last match that isn't even on here is a lot of our administrative costs are 50-50. So the point that I'm trying to lay out is we get different match rates for different programs for different purposes throughout it, but we do get a significant amount of federal match. This sort of just meant to show the history of how you can see the FMAP goes up, the FMAP goes down. And what I was trying to show on the side here was that sometimes you can see that the FMAP is tied to economic downturns. So we had temporary fiscal relief in the early 2000s. There was an economic downturn then. Then during the American reinvestment, the ARA period, that was the Great Recession. Then there's a little bump during the Affordable Care Act. That was Senator Leahy trying to provide us with a lot of the states that hadn't been doing expansions were getting all this money, but the states that had done expansions weren't getting any money. And Leahy was like, that's not right. So that was like a bump that we were the only state that got for a short period of time. I guess it helps to be the chair of the Appropriations Committee. And then the other, what's that? Yeah. And then with that last one is this, we had a 6.2% FMAP bump during COVID. So this is just meant to just sort of show, so sometimes we get these additional, because it's an easy way when times are bad and the federal government wants to help states out, this is an easy way to get money to states, particularly because low-income folks are often hit the hardest during these periods. They lose their health insurance, etc.
But the problem with the FMAP calculation in that goes is it usually is a year out. They reset every year.
Yeah.
So if you head into a recession, the first year of the recession is bare because they don't reset those numbers.
And it's based on historical.
Yeah.
So there is a lag.
So you end up with this lag. So at times you can be 18 months into a recession before, and then so it's just.
And if you look at the ARA period, you can see that there was a lag. There was 2 years, and then the FMAP came in after the ARA period, right? So there is a lag.
It's always good to have some reserves when you start a recession.
Now we're going to move into global commitment. This is a term you're going to hear a lot. I'm going to pass the torch back to Ashley to talk about this.
Thanks, Nolan. I'm just noting that it doesn't look like, oh, there, can you see me? I'm sorry. This has been a weird Zoom. Okay, thank you. Sorry. So going into global commitment, I'll first talk about what an 1115 waiver is. As I said before, the Medicaid program is authorized through the Social Security Act. And in that Social Security Act, there are specific laws that say the federal government will pay for these services for these people under these circumstances. What an 1115 waiver does is actually waives those laws and says if states want to put on a demonstration that is innovative and will be at least budget neutral, then we will waive those provisions and let you do something different than what we authorized through the Social Security Act. It's called an 1115 waiver because it's 1115 of the Social Security Act that allows this. The big hook with waivers is that you cannot spend more with a waiver than you would have spent without a waiver. Budget neutrality is king when it comes to 1115s. If you don't have a waiver, it means you are strictly limited to what is in that Social Security Act, and you cannot do anything outside of that. Most states have some form of an 1115 waiver. We are the only state in the country where our entire Medicaid program is authorized under an 1115. So when we're talking about our 1115 in Vermont, we're talking about our Medicaid program. They're one and the same. Every other state who has an 1115, it is more discrete. It might be focused on behavioral health or prescription drugs or kids. Ours, as I said, is everything. We've had the global commitment since 2005. We amend it every so often to get new authorities and flexibilities, and it expires every 5 years. So every 5 years, we have to go and get a renewal. The current term that we're in right now was authorized in 2022, and it ends at the end of 2027. So what our waiver does for us is essentially two big things. It gets us federal money that we wouldn't otherwise be able to get without a waiver, and it gives us flexibility to do things differently than we would have to do without a waiver. On the money side, it allows us to pay for populations and services that wouldn't be authorized otherwise. Those are the marketplace subsidy program for people getting Vermont Health Connect getting a health insurance product through Vermont Health Connect. It pays for wraparound services for individuals experiencing severe mental illness or substance use disorder who are higher income. Then they're not eligible for Medicaid because they're higher income, but we provide a wraparound benefit to ensure that they have access to behavioral health. We have a moderate needs group, which allows us to offer Medicaid-like services to individuals that aren't Medicaid eligible in an effort to prevent them from becoming Medicaid eligible and ending up in a nursing home. So moderate needs is for older Vermonters who don't meet nursing home level of care, but are close. And we can actually come in and use Medicaid dollars to help keep them in their home for longer before they ultimately have to end up in a nursing facility and then become Medicaid eligible. We have a children's palliative care program, which provides palliative care services for terminally ill children. We have a category called investments, which we'll get into in more detail later in this deck. And then most recently, as of one of this year, we are standing up a permanent supportive housing program under our waiver, which provides tenancy and pre-tenancy support services for individuals who have experienced homelessness. And also, we have not implemented this, but on January 2nd of this year, we just amended our 1115 waiver and were granted authority to pay up to 6 months of rent or 6 months of medical respite for individuals experiencing homelessness. This is not a benefit that is enacted right now. We just got this authority a couple of weeks ago and need the state funding in order to do anything with this. But it is notable that we now have this authority. That is the money piece of our waiver. On the flexibility, the key thing that our 1115 waiver does for us is it sets up the Department of Vermont Health Access as a managed care organization. Because Vermont Health Access is managed care, we are able to adhere to managed care laws, which provide a lot more flexibility in how we pay and what we do with our money. The alternative to managed care is fee for service. So I think you all know in Vermont, we are really big on alternative payment models, participating in the all payer model agreement, potentially participating in AHEAD, working on value-based payments. That is all because we have this managed care construct.
Ashley, we have a question.
Yes.
Ashley, thank you. My ears pricked up with the bullet point as of 1/2/2025, up to 6 months of rent and medical respite for people experiencing homelessness. Can you fill in any more detail on, Nolan suggested it was a 5-year cap.
Well, I'm talking about for the total waiver.
Yeah. Oh, I see. What would it look like in terms of how much we could access in a single budget year of that?
So there are lots of strings, unsurprisingly, associated with Medicaid dollars paying for housing. This is a first. CMS has never done this before. Vermont is not the first, but this set of waivers that have been approved this year are brand new, and they have a lot of strings. So one thing is individuals must be Medicaid eligible. They must be homeless or with a history of homelessness.
I'm sorry, I can't hear you. Could you repeat that?
Homeless or have a history of homelessness.
Yeah.
The funding cannot be used to pay for brick and mortar, so we can't actually build units with this.
But could you, for instance, could you plug it into the GA program as it currently exists?
As it currently exists, no. We also cannot supplant existing state-based funding. So anything we do around this funding would have to be above our base housing budget. That wouldn't include things that aren't in our base that we've been using to pay for housing over the past 4 or 5 years, but it does include base GA.
Okay. Very interesting. As we come up on that discussion in the BAA, it would be good to hear more about the possibilities, even with the strings, for trying to do more for the GA program than we've done currently.
Definitely. I think it's a really exciting opportunity. I just want to temper that there really are some serious guardrails from CMS's perspective, but I think it can be really promising for Vermont.
Okay.
Getting into the flexibility a little bit more, just to put a point on this managed care construct, because I think it's really an important piece of our Medicaid program. When you look at most state Medicaid programs, they contract with private managed care organizations, Aetna, United, Kaiser. They're paying those companies to be their Medicaid insurance plan. In Vermont, we've set up a system where we pay DVA, the Department of Vermont Health Access, to be our insurance plan. In other states, those insurance plans, Aetna, United, Kaiser, they are working to provide services at the lowest cost they can so that they can keep the funding and pay their shareholders. In Vermont, we are working to keep costs low, but instead of paying shareholders with the savings, we are reinvesting it in our Medicaid program. And so that's where we, again, we'll get into this in a later slide, that's where we come up with this category of investments. And it's important to just understand that model. So our investments are essentially what would be profit for a private managed care organization in another state.
No, how much more time do you need?
I would say five more minutes.
That'd be good.
Let's skip this next slide then on the delivery model, Nolan.
Skip this one?
Yeah, skip that one.
Okay.
Okay, this is really, I think, more of a reference. It is a different way to say what I said at the beginning about the waiver giving us funding and flexibility. These are our populations covered under our Medicaid program. And at the top half of the slide, allowable without waiver, these are the people that have full comprehensive Medicaid coverage, and they would have it with or without our 1115 waiver. The bottom half of the slide only exists because of our 1115. If our waiver were to go away, all of these things would also go away. V-Farm, our mental health program, moderate needs, our SUD expansion program, and the marketplace subsidy. Those are exclusively available because of our global commitment. On the other side, waiver only expenditures, we similarly are only able to pay for this because of our waiver. I think this is just a nice slide for people to be able to reference when they think about, like, what is our waiver getting us? It's getting us the bottom half of this slide. We can go to the next one.
This is our last slide.
Okay. So investments, we saved, they got their own slide because it is just a really cool concept and something that I think is important for legislators to really understand the flexibility that we have in our Medicaid program. So as I said, managed care-like model, instead of profit, we get savings. We then reinvest those savings on things that cannot otherwise be paid for by Medicaid programs. We're the envy of the country in terms of our ability to use federal Medicaid dollars to pay for things that the feds will not pay for under any other circumstance. It's a really special, cool thing that we have. And we use it to the tune of about $120 million a year in things that we're getting federal match for that we otherwise couldn't get federal match for. We have 69 investments as of now. A lot of these have been in place since 2005. We're working on doing a really holistic evaluation of these investments. Some of them are really working and making the impact that was intended, and some of them it's less clear what effects they're having. And so we're really trying to dig in and understand the efficacy of these different investments. Just to give you an example of what some of them are, one that I always cite is federal match to pay for the Department of Health's public health lab. 211 is paid with investments. Hospital diversion is paid with investments. HEC, the student loan forgiveness for medical providers, all of those are investments.
And I can send along to Al a list of those investments for anyone who wants to see what they are.
If you go to the online, the link does work.
Oh, the link does work. It wasn't working earlier. Oh, it is working now.
It
Okay.
didn't work this morning,
But it's
I
working
think
now.
It'll work later, yeah. Can I ask a question?
Yeah.
So, and I don't know whether Ashley knows the answer. It's really, I think, for her, could be from you, but we heard this morning, Ashley, from AHS, from the secretary and another member, a person in charge of Medicaid, that we're going to be getting more funding for mental health and for helping kids in schools. We're not going to be leaving money on the table, so to speak. Can you talk about that a little bit? Because I think it could have implications both for approach and then for education.
Yes, I haven't had a chance to read those notes yet, but that's exciting that that came up. We are working on a really exciting project with the University of Massachusetts and the Agency of Education to revamp our school-based services program, which is essentially special ed and mental health services provided through schools. It's a massive part of the school budget. And we know we are leaving money on the table. So we are revising that methodology for how we are paying and reimbursing schools so that we can maximize the federal money coming in. And also are looking at efficiencies so that we can reduce the administrative burden on these schools and make it easier for them to actually bill Medicaid. So we got a federal grant to do this work. It's super exciting. We're looking at fall of 2026 for implementation. So we've got a little bit of ways to go, but as you can imagine, it's very complex, but exciting to be able to talk about it.
We have another question, Senator Watson, and then we'll end.
Thank you. So very exciting, to think about the revamping of the school-based programs and not leaving federal money on the table. I guess my question is logistical around, if the global commitment plan is renewable every 5 years and not due until 27. So is this some kind of like an interim adjustment, or we get to make those kinds of decisions ourselves without checking with the federal government? I guess I'm wondering, like, how are these updates being made in the interim?
Yeah. So the global commitment waiver is a framework for how we administer our Medicaid program, and things that are paid for exclusively through the waiver, so the bottom half of that slide, are spelled out in detail. You're covering the moderate needs group under these circumstances, and you can only spend this much of money. Everything on the top half of the slide that could exist without the waiver, we have a broad discretion over. It's not spelled out in the waiver. We don't have to amend anything in order to make changes to our basic Medicaid program. So the bottom half of that slide, we'd probably need some amendments if we were doing big changes to it. Top half of that slide, we can do lots of things without CMS, and school-based services fall into the top half.
Okay, thank you.
And then I just want to make one last point, and then I'll shut it down.
Shut it down.
All right. We talked about before how, the state contract, usually we'd contract with managed care entity, but for us, we'd contract with DIVA. For the budget, Medicaid is duplicated in the budget because you'll find it's appropriated to the Agency of Human Services. That's where it gets matched. So the general fund goes there, it'll get matched with the federal funds. And then it may show up as a state and general fund, but it also usually will show up as a global commitment fund in the agencies. So later on, when you see why is this in their global commitment fund, when you see something under the GCF, when you're looking at your ups and downs, that's actually state and federal, but it's combined in one piece. I just wanted to put that seed.
Is that the global part?
Yeah, that's where it's mixed. So it might be in DMH and under the Global Commitment Fund, but there's actually state and federal, but it's just matched as a gross fund there, but in the AHS, it's counted in both.
That's another example of when we have unduplicated reports.
So I just wanted to flag that because this is one of the committees that really needs to know that the most.
Yeah, and it's a big number.
Yes.
Okay, thank you. Okay, we're gonna talk about ed funding and appropriations, but I wondered if people wanted a quick stretch break.
Uh-huh.
Sure. Let's do that.